Yes. So can you see my screen? Hello?
Yes, Dr. Vinayak, your screen
Yes.
is visible. You can continue.
Yes, I can start, right? Yeah. Okay. So thank you, Dr. Rohan, for the introduction. Yeah, it's been a long journey now since from 2006, I guess, that we know each other. And yes, we both have come a long way. So I will now start with CBCT and how to read it. So we all want to live a peaceful life, a life free of disasters. There are certain disasters which we couldn't avoid in our life, but few which we definitely can. For example, if you see this slide or this image, you will see that this implant which is there, this is touching the root, right? Which could have been avoided. Now, if you see here the purple part is the nerve canal, and if you see the implant is touching the nerve canal or impinging on the nerve canal, which also could have been avoided, right? Here, if you see, there is discontinuity of the lingual cortex. But when we are doing conventional implantology, this is not needed, right? So again, this could have been avoided. So if you see these images, what you can see here, that this implant, no, it is too distally placed, and these two implants are very close to each other, right? So all these things could have been avoided if a proper planning would have done before starting the treatment, right? Now that the world is evolving, we are not behind. We have also evolved in the world of technology, in which the graphics has improved, the memory has improved, and the processor speed, everything has improved a lot, right? The implantology now has improved from conventional implants to we have pterygoid implants, zygoma implants, sinus bypass, nerve bypass, all these things are there. And even in the field of radiology, we have come a long way from IOPA to CBCT scan. So IOPA is still the gold standard in our radiography or diagnostic radiology, but the disadvantage is that it's two-dimensional representation of a three-dimensional structures. So we can never see the width of the bone on an IOPA. And secondly, there could be elongation or shortening depending upon what angulation we give. Right? Next came OPG. The advantage with OPG was it covered the entire region, whereas IOPA gave only a localized region. But the disadvantages of IOPA persisted with OPG, that it was a two-dimensional representation of three-dimensional structures, plus there is a lot of elongation in OPG. So all these OPG images are elongated. And what we needed for implant planning or to see an object in all the planes was a third dimension, which is the meso buccolingual wave, which you see here. So that we first got in CT scan. So CT scans were the first modalities which gave us the three-dimensional view. But the disadvantages of the CT scan were that the dose was too high. Secondly, it was too expensive. And third, the image resolution was not that great. So all these three problems were solved by CBCT. So in CBCT, the dose which is there, it is 99 times less than that of the CT scan. The time required is less, and the cost is also less. So the latest development in field of our dental radiology is CBCT. Right? So with the help of CBCT, we can do our implant plannings in high quality software. So what the CBCT stands for? CBCT stands for Cone Beam Computed Tomography. That is the full form of CBCT. And it is also the third eye in diagnosis and treatment planning. Now my aim in this lecture is to make you read a CBCT scan on your software. So when you open the images on your computer, you should be able to read that scan, and what part it is, where it is. So I won't be going much into the acquisition or the principles of CBCTs. I will just give a brief idea about it, and we will focus more on reading basically happens in the CBCT scan? So it is just like an OPG machine. We all know how a OPG machine works, right? There is an X-ray source and there is an X-ray sensor. And source and the sensor will revolve around the patient, right? And while revolving, the X-ray source will emit radiation and the sensor will capture it. Now, what's the difference between OPG and CBCT? First is the X-ray source. In CBCT, the X-ray source is cone beam. So, in a single rotation, the entire region is scanned with the help of the cone-shaped beam, right? And secondly, the sensor. In your OPG, the sensor is your X-ray film, which is a single dimension thing, right? And you can see structures in 2 dimensions. But in CBCT, the receptor itself is a 2D object, right? So if it is a 2D, it will record all the objects in all the 3 planes. So that is the basic difference. So what happens is your X-ray source and the detector will rotate or revolve around the patient. And while it does so, the X-ray source will emit radiations or X-rays one after the other. And there are series of hundreds of X-rays done. The way a machine gun shoots, in a similar way, the X-ray source will shoot the radiographs, 2-dimensional radiographs, one after the other. And while approximately 600 to 700 such radiographs are made, these are called as raw images. Right? And after that, the software will join all these things and you will get a 3D image which is called a projection data. So in short, what happens is the X-ray source and the sensor or the detector will revolve around the patient. It will take hundreds of images which are then joined and what you get is a 3-dimensional structure. So this process is called as primary reconstruction. Then when we open it in our computer on the software, we can see it in different planes. That is called as secondary reconstruction. So this is the basic introduction to CBCT, how it works or how it operates. Now, in order to read a CBCT scan, we should know how these structures appear on the CBCT scan, right? Then only we will be able to know what it is. So, first we will divide it into 3 parts. First is tooth and supporting structures, second is air structures, and third is soft tissue structures. So the tooth and supporting structures will appear the way they appear in your IOPA, RVG or CBCT. So whatever odontogenic infections are there, teeth are there, periapical areas are there, bone, everything will appear the way they appear on your IOPA or your OPG. Secondly, whatever is soft tissue will appear green. So your tongue, your gingiva, your lips, your buccal mucosa, your soft palate, your mucosal thickening in the sinus, everything will appear as green. And whatever is filled with air will appear black. So whenever we are seeing any cavity, like maxillary sinus, you have your oral cavity, you have your nasal cavity, all these 3 things will appear black, right? So this is the basic to read a CBCT scan. So whenever it is filled with air, it will appear black. Whenever it is made of soft tissue, it will appear gray. And teeth and supporting structures will appear the way they appear in the IOPA or your OPG. So if you see these images, if you see the first image, this is the axial section which is through the axial vertebra. So it is like you are seeing from the top or bottom. So when we are seeing a bony structure from the top of a bottom, at the side of the bone, see the bone always has cortical plate at the side and inside is your cancellous or marrow space, right? So if we were to read this white part which is there, if you can see my cursor, this white part is the buccal cortical plate, this white part is the palatal cortical plate, and the inner black things with whites are your alveolar bone. This round white structures is your root. So it's a cross section to the root. So these are it's the dentine of the root. And the dots which are inside are the pulp canals. Right? So this is the pulp canal, this is the dentine, radicular dentine. And you will see a line surrounding it, that is your PDL space, and then a white line surrounding it is your lamina dura. So it is the basic what we learn in our third year OMR radiology posting, right? What is radiopaque and what is radiolucent? Right. Similarly, if we see this third image, this extremely white part is the enamel, right? Because it is the most radiopaque. Then you have your denti. Then the black part is your pulp canal, and this black lines are your root canals. Now, if you see this, where this is ending, this is the floor of the maxillary sinus, and this black part is the maxillary sinus, right? It is so simple to read a CBCT scan. But this black part is the root canal, this black is the maxillary sinus, and this is the lateral wall of maxillary sinus. Okay, everyone is with me?
Yes, Dr.
Yes, Dr. Yes. Okay. So now we have seen how the teeth and teeth structures appear. We will see how the restorations and things will appear. They will also appear the same way. So if you see this section here, this bright part, radiopaque part is the restoration of the top. And if you see this patchy thing in the root canal space, that is your sealer. See, if you see this white part, it is the buccal cortex of the bone. This is the lingual cortex of the bone. Here you can see the buccal curvature of the root. How root is curved buccally. And this black part is the periapical abscess, which is radiolus. Right? So these are the three basic things. Now here if you see, same thing, the black dots are the pulp canals or the root canals. Right? The white part is the buccal cortical plate. This is the palatal cortical plate. And the inside part is your trabeculate bone. So marrow spaces and trabeculate. Same here, the cortical bone, outer cortical bone, as in that is buccal cortex, palatal cortex, and the cancellous bone. Now, if you see here, the bone, you see the normal structures, how they are. There is continuity of the structures. There is this architecture which is there of the marrow space where you see radiolucent and radiopaque lines going through it. Right. So this is how a normal bone looks like. Why I am saying this? See, only when we know the normal, we will come to know the abnormal. So if you see this first slide over here, number 26, see it is all normal, right? The labial cortex is intact, the palatal cortex is intact, and we can appreciate the bony architecture. Now, as we move ahead and you come to slide number 30, you will see that the labial cortex is thin. It is expanded, there is discontinuity of palatal cortex, there is loss of normal architecture of the alveolar bone, right? So all these things are suggestive of some pathology, right? Now if you see this, these are the sections on the top. So if you see this black line here, this is maxillary sinus, right? This black line is oral cavity, and this is thickening of the maxillary sinus. Hence this is appearing gray, and this is appearing black. Same thing. So now we know how the structures appear, but where do we see them? So there are certain planes, there are certain reconstructed views, and there are some three-dimensional views. So the sections, the body is divided into three sections. First is the axial section, is through the axis vertebra. So whenever we are seeing an axial section, it is like we are seeing from the top or we are seeing from the bottom. So this axial section is good to see the root canals, the number of root canals and the pores they travel, and also to measure the width of the alveolar bone. So this is the axial section. Then you have coronal section, which is parallel to the coronal suture. So whenever we are seeing from, it's like we are seeing from the front or we are seeing from the back. So this is the coronal section. Sagittal section is parallel to sagittal suture, right? So whether it's like we are seeing from the side. So either we are seeing from the left or seeing from the right. So these are the three planes in which the body is divided: axial, coronal, and sagittal. Then there are some reconstructed planes, right? So one of us reconstructing is the cross section. The cross section is the buccolingual view through any area. Now see, this is the buccolingual view to anterior region. This is the buccolingual view to posterior region. Can you see? So why I am using the term cross section? If you see here, to get this buccolingual view in the anterior region, I am seeing this way from front to back, right? So this is the sagittal section. But to get the same buccolingual view in posterior region, I have to see from left to right. That is the coronal section, right? So it becomes confusing which is sagittal, which is coronal when you have the buccolingual view. That is why we just use the term cross section whenever we are seeing the buccolingual or buccopancreatic view of the Cbct scan. Then we have reconstructed panoramic view. This means that we can draw our own panoramic view. We can draw our own arch. So this is the reconstructed view. Okay. So these are two different things. One is the sections and second is the views which we have made. So depending upon that, the arrangement of these sections, there are different views which are present in our software. So there is a view called multi-planar transformation view. In this view, we will see the object in all the three ABCs. That's why it's called as multi-planar. So here this is the adjacent plane, here is the coronal plane, and here it is the sagittal plane, and this is the 3D view. So all these things are what you see is there is an impacted first premolar. Now from this image itself, we cannot say whether that premolar is buccal or palatal, right? But when we take a CBCT scan, we can say that this tooth is palatally placed, right? Plus we can also check if there is resorption of the root or not. Another example here, if you see there is an impacted forehead, right? And the nerve canal is very close to the root. We don't know whether it is buccal, whether it is lingual, or whether it is actually touching the root. But when we take a CBCT scan, see we can see that the purple part here is the nerve canal, right? So we can see that this is the root has appeared now. This is lingual to the root, right? And it is compressed between the roots and the lingual cortex of the mandible, right? So this is how we can identify the relation of the nerve to the tooth. Next you see here, if you see these two it is fracture. If you see here, there is a fracture at the Cbct, right? But the exact nature or exact line of this fracture line we cannot detect in the 2 Cbct. But when we take a CBCT scan, we can see it in all the three cases, right? So this is the advantage of CBCT over OPG. Now if you see this, here there is an impact, what is it? Ill-defined radiolucency around 2.6, right? Medium upper root of 2.6. And you can see that the observation is also slightly short of apex, right? So, but when we take a CBCT scan, see the cross section, we can see there are two canals in the medium upper root, right? MD1 and MD2. Here the MD2 is filled and MD1 is missing. Also, the observation is short of apex, right? So this MD2 canal presence is seen only on the CBCT scan. Also, you can see a small periapital radiolucency here, and this is a mucosal thickening. Like I said, the gray part is always the tissue. So the soft tissue growth in the sinus is dome shaped. So it is benign mucosal thickening of the maxillary area. The next important thing in CBCT is field of view. So field of view is nothing but the area which is covered by the scan. So this field of view can be large, it can be medium, it can be small, or it can be stretched. Now, this field of view is always measured in centimeters. So whenever it is small, we call it it's a 5 by 5 or 4 by 4 feet. So that means it covers 5 centimeter by 5 centimeter by 5 centimeter in volume. 4 by 4 will cover from 4 in volume. So that is how our field of view is measured. Now the advantage, why we need to know is because when we want to go an endo scan, we will always go for a small field of view because it will give us good resolution. And also we need to know what is the stretch field of view. So stretch field of view is when the field of view is lesser than the area to be scanned. For example, if the field of view is 5 by 5 centimeters and you want to scan the entire mandible, it cannot scan. So it will take a 3 segment scan, right, anterior and left, and it will join the 3 scans. So that process of joining is called as stitching. So that is the stitch technique. So now therefore we will do whether cases along with glaucoma, pterygoid, etc. So we can go for large field. Whenever it is a single arch, we can go for a medium field. And when it is a single tooth or something, we can go for a focused or limited field of view. And stitch, like I said, we will take multiple scans and they are joined by the software. So these are the different field of views. So we see the sections, we know how to see, how to read the structures, right? And so how we will know when we are reading those structures in sections in which region we are. That is possible only because of certain landmarks which help us identify the region we are in. So for example, if you see this bridge, it is a landmark that we are in Mumbai, right? So similarly, there are landmarks which will help us in identifying the CBCT scan or reading the CBCT scan. Right? So in maxillary anterior region, the major landmark is our nasal cavity. So the nasal throat is the first landmark which is seen, and then there is something called as anterior nasal spine. So it is the extension at the anterior end of the the maxilla, and it is the junction. It is where the maxillary bone ends and nasal bone starts. It is important that we know where it is. And another major landmark is your incisor foramen of the nasal adjacent foramen. So it is present in anterior region and parallel to L1 and L1. Now in the posterior maxilla, your major landmark is your maxillary sinus. So if you see this, the very black part is your maxillary sinus. The gray part here, gray is soft tissue. So this is the mucosal lining of maxillary sinus. And this white line is at the floor, it is the floor of the maxillary sinus. Then we have the alveolar bone, and this is the alveolar crest. And this is the restoration of the process. Right? So this is again the maxillary sinus. And it is dipping between the tools. Now the sinus itself has many very complex structures. So first is the osteometal complex. The osteometal complex is the opening of the maxillary sinus into the nasal cavity. So it occurs in middle meatus. So it is a non-dependent gradient. So we have to see that the ostium, this connecting part, is patent when you are doing a sinus lift. Second is posterior superior alveolar artery. So this runs around the lateral wall of the maxillary sinus. So it can be superficial if it is on the outer surface. It can be intraosseous, which is inside the bone, or it can be intersinusal, that is on the inner surface. Then there are septals in the sinus. So whenever you see these radiopane lines into the sinus, these are the septals extending into the maxillary sinus. Now, two more major landmarks in the maxilla. First is the zygoma. So zygoma is the cheek-like bone which is present. So it will be lateral to the maxillary sinus. And the next are your pterygoid plates. So this pterygoid plate has two in number on each side. There is a medial pterygoid plate and there is a lateral pterygoid plate. So whenever you palpate the bone after tuberosity, we feel a ridge and then there is a pterygoid hamulus, a notch-like structure. And after the pterygoid hamulus are your two pterygoid plates. One is the medial pterygoid plate and second is the lateral pterygoid plate. So these two are the pterygoid plates. This is medial, this is lateral. Okay, here again medial pterygoid plate, lateral pterygoid plate. So these are the landmarks in maxilla. We have a nasal cavity, anterior nasal spine, nasopharyngeal canal, maxillary sinus, zygoma, and pterygoid. Now in mandible, the major landmarks are in the anterior region, first is your gingival. Also you have the liver foramen. So the advantages of these help in identifying the center of the mandible, because the liver foramen is always at the center of the mandible. At the center of the mandible, and the gingival foramen next to it. So there are two significances that this lingual foramen is out of the mandible. So whenever the blood vessels which are carrying are injured, the bleeding would be into the sublingual space and cause sublingual foramen. So it is always necessary avoid using of the lingual foramen. Secondly, they act as a equidistant point. So it's at the center. So when we are planning over here, so we can take this as a center and select our areas equidistant on both sides. Then we have this mental fossa. So mental fossa is the depression on the radial surface. It will affect the angle of implant position. Then we have your posterior region, is your premolar region first, is your mental foramen. So the mental foramen is the area from where the So it will be a round opening here on the bone. The second thing is related to mental foramen is the anterior loop of foramen. So most of the times the nerve doesn't come out straight in the 5 region. It comes ahead in the 4 region and then goes behind. So there is a loop-like structure anterior to it. So that is called as anterior loop of inferior alveolar nerve. So whenever we are placing implants in 3-4 or 4-4 region, we need to the anterior loop. We'll have to plan such that we avoid any injury to the anterior loop. Okay. And then you have your mandibular canal. So it's a band-like thing, also seen as a round dot. And in the posterior most region, you have submandibular salivary gland fossa. So this is mostly seen in the 7th region where there is some the fossa because of salivary gland. Right? So if you see here, if I'm drilling straight, my drilling will be 10. That is the restriction because of the fossa. Right? So the landmarks in mandibular are genial tubercle, lingual foramen, mental fossa, mental foramen, anterior loop of mental foramen, inferior and your this thing, mental fossa. Okay? So these are the various landmarks which will limit your implant placement. So after that, we will see the applications. Right? So the Cbct is applicable in all the fields of dentistry. Right? And we will see pertaining to implant planning. So in implant planning, we can do is we can determine the bone height and bone width. We can determine quality of comparative dentistry. Now in Cbct, we never get the accurate bone density. We always get a relative or subjective bone density. Why? Because Cbct bone density is generally measured in Hounsfield units, and that is peculiar to CT scan and not Cbct scan. Is any question?
Take up in the end.
Okay. There was a hand raised, so I thought.
But continue so that your continuity is not broken, and then in the end we take it up.
Okay, sir. Yes. Right. So in Cbct we get a subjective bone density as the Hounsfield units are not related to Cbct scan. So thirdly, we can see the long axis of the bone, so we know in what direction we are planning. We can see landmarks such as nerve canal and sinus cavities beforehand, so that we can plan accordingly. We can determine the boundary and check for pathology. So overall, what you do in an implant surgery is you raise a flap, and when you see the bone, right? But what you see is the outer bone. But in the Cbct, you will see that entire bone on your computer. Outside and through the slices, we can see the inside of the bone. We can see where the nerve canal is. So this is the biggest advantage which we get, that your patient which you will be going to treat in his mouth is exactly in front of you. The way it will be in the surgery in a better way, where you can measure the bone which is there and see where your nerve canal is, see where your sinus is, and you plan your implant so that it is properly there. Right? So that is what you can do with the Cbct scan when you open it on your computer and you see the patient on your computer before you do it in the surgery. So bone height measurement, the bone height can be measured from the crest to the nearest landmark. So now we are seeing the scans and everything, we have a rough idea. Now if you see here at the bottom there is a OPG view and at the top there are cross sections. So if you see there are 3 vertical lines, so these are sections corresponding to this. So this 2 images together they help us understand that what area we are doing our planning. Secondly, if this is not there, then the anatomic landmarks and the shape of the bone will give us the idea. So now, for example, this is maxillary anterior region, right? Seeing the cross section of the nerve. See the height is measured from the crest till the canal. This is the nearest landmark over here. white line is the anterior distal spine, and this above part is the nasal cavity. Right? So in the posterior region, the height is measured from the crest till the floor of the maxillary sinus. In the anterior region, we have measured this from the crest till the inferior border of the mandible. Here it is measured from the crest till the mental nerve. And posteriorly it is measured from the crest till the inferior alveolar nerve canal. Right? Now, the measurement distal nerve canal, the implant conventional case would be slightly short of it, 2 mm short of it. So these were all ideal scenarios, but now clinical cases will never see that. Right? Periodontal we see such cases. Now if you see here in this image, one file is missing, right, which we have to replace by an implant. If you see there, the nearest landmark is the floor of the maxillary sinus. But here the water trick is that the floor is sloping from anterior to posterior. As a result of this, the height which is measured here is more than what is measured here, which is even more than what is measured here. Right? So if you see here, the length is more, we have got 15.5 mm. Here it is 14, but then it is 12.5 and constant. Right? My implant size in this case should be 12.5 or 12 mm and not more than that. Otherwise, what will happen? It will protect it to the sinus. Then if you see this case, if you see here, like I said, the black part is the head. Right? So this is the part of the cavity, and this is the part of the maxillary sinus. So if you see here, the sinus has come down completely. Right? So when I am measuring height, right? It's the same size where the height difference is there. Right? So you need to measure in the angle in which we will be placing the implants. Because what happens most time, your radiologist or Cbct center will measure in one angulation. We place implant in another angulation, and then we feel that the Cbct is not accurate. But that is not the case. It is that the plannings are not matching. So you need to make your own plan before you place the implant. Now here if you see, this is an extraction socket where the buccal bone has been removed or buccal cortex has been fractured. Now in this case there will be two options. One is either we restore this bone and use palatal height as the height, or what we can do is we have to remove this osteotomy, osteoplasty, and then use the buccal plate as the height. Right? But in this case, the abutment would be larger in size and the processes would be a problem. If you see this image, there are two slices of the same section. Now one, when I'm measuring them straight, I'm getting 11 mm, and when I'm measuring them at an angle, I'm getting 13 mm. So you see the difference when I'm measuring at the same side. I'm just angulated and I have got 2 mm more. Right? It is a Pythagoras theorem where the right angle is always larger. So when you tilt it, you will get more length. Right? This is how we measure the height. Similarly, in the same fashion, we can measure the alveolar width or the bone width as well. So the widest and the narrowest width can be measured. For example, if you see here, this is the width at the crest. In some cases, the width is narrow at the crest and wide below. So what we can do is we can measure how much apical that part is, the wider part, and then measure at the wider part. Now if you see this image, it is a very interesting image in which it is a panoramic view above, which is a two-dimensional representative of two-dimensional view. Then there are cross sections below, right? So if you see just the OTG view, if you hide the slices, we will think that there is a very good height there. And if you see the cross section, you see the thickness of the soft tissue over here, See, 1.5 is the width of the bone, but the soft tissue surrounding is double this size. So this could be approximately 2.5 and 2.5 there, buckling. So the clinically, if you see this, it will appear as a wide range. So what a doctor will say that there is good height and good width, right? But when you open it, then only you come to know that the ridge is very narrow. But this thing can be seen first hand itself on a CBCT scan, where we can now plan for either grafting or with split or any other treated implant technique to avoid this problem. Presence of undercut. Like I said during landmarks, the mental fossa or your sublingual salivary gland fossa, they provide, because of this there is an undercut, and if we drill below through that, we will end up into the what you say submandibular fossa. For example, if you see here, if I measure only on this OBG view, which is two-dimensional view on the bottom, my height is 15 mm. But if I drill 15 mm straight, after 10 mm, I will drilling outside the bone, right? So either I have to drill straight 10 mm or tilt it and then use 15 mm as my height. Next thing which we can measure is the angle. So we can measure with the angle tool, the angle at which the implant is measured. But this angle cannot be easily transferred, because we don't know this is 20 degree, 30 degree when we are doing freehand. So we need a surgical guide to transfer this thing. And one more thing which we can measure or see is the presence of pathologies. So here if you see there is a root piece present. Here if you see there is periapical infection which is there, right? Severe osteomyelitis. And here if you see there is discontinuity of the labial cortex with the extraction socket in place. Right? Now coming to bone density. Like I said before, the bone density in ounce unit is pertinent to CT scan. In CBCT, it is not that accurate. So we do not follow that. So what we need to do is we need to see the subjective bone density. That is, we need to see whether the bone is hard or whether the bone is soft. So if there are more of trabeculae and less of narrow spaces, the bone will appear hard, right? So if you see here, the first part here where the trabeculae are more and narrow spaces are less, this is the D1 type of bone, right? So it is a hard bone. Here if you see same, it is more towards the wide or brighter side with less trabeculae. It is again a harder bone. If you see here, the size of trabeculae has increased, right? And you see this, so this is a soft bone. This is the last image. It is the softest bone, right? So this is towards D4, but you see how black it is. So there are bigger narrow spaces and less cortical bone, right? That is how we can subjectively assess whether the bone is hard or whether the bone is soft. If there are more trabeculae and small narrow spaces, the bone is hard. If there are small, less trabeculae and large narrow spaces, then the bone is soft. Also, one thing which we can do is after measurement, after seeing the bone quality subjectively, we can place a virtual implant. We can tilt it into different angulation. We can adjust the height. We can adjust the length. And we can do a virtual implant placement as well. Right? So the advantages for the reference dentist because of this is CBCT is that we can visualize abdominal anatomy that cannot be seen externally, right? Bone also, if we see in a normal surgery, we will see from the outside. We won't see what is the wall, what is the bone inside, how much is the bone. All the things cannot be seen clinically, but they can be seen in the CBCT scan. We can also analyze and position where the nerve canal is, where the maxillary sinus is, where the roots of the adjacent teeth are, right? All these things can be analyzed. We can assess the risk if these are close to the bone, and we can plan the treatment surgery accordingly. So scope for improvements in CBCT would be soft tissue contrast. Like whenever we saw, we got good definition of hard tissue, where we can see enamel, dentine, right? Cortical bone, marrow bone. So there was good contrast. But in case of soft tissue, right, it is always gray. We don't know what is inside, how it is, what it is. So whenever we see gray soft tissue, very soft tissue, right? So that is where we need to improve the Cbct scan. And second is deriving Hounsfield units. But what will happen to derive the Hounsfield units? You need more exposure, more X-rays, and more data. So that will convert the CBCT scan into CT scan. So I don't see these things happening in the future. Now, in order to get a good report from your CBCT scan, most of us we send the patient to diagnostic centers for our CBCT interpretation, and they make a report and send. But if we give a good represent of what we want, the radiology center will be able to send us a good report. It's like you go to a restaurant and order food. So you are specific that you want this, you want to eat this way. And then the waiter will get that food. You just cannot say that you give me food and he can get everything and we then tell I want this and I can't eat this, right? So we should have a prescription of our referring patient where we must mention the purpose of the scan. When we want implant planning, we should mention which regions we have a plan to put implant. When we get a report, a written report or the slice reports, the distance between the two images is what is the interface distance. So we can tell the center what we want, 1 mm, 2 mm. We can also measure the format we want, that is clean images, with measurements, with planning, right? With nerve marking or without nerve marking. We want a report in CD format, in mail format, in printed format. So all these things will help you in getting a better report. And last thing is you need to give a brief clinical history. So whenever you are sending a patient for some pathology apart from implants, you need to give a good history so that the radiologist can correlate the findings and the history which is done. Because malignancy and periodontitis both appear same on your CBCT or any radiograph. Right? So to distinguish it, we need to have this thing. Right. So this is about the CBCT. Any doubts, any questions you want to ask me related to CBCT? We can discuss now. Hello. Hello. Uh,
Hello, yes, sir.
yes. So I have done with the CBCT part. So if there are any questions on CBCT, then you can ask me.
Yeah. Dr. Chandran, just put up your question. I'll just read it out for you, sir.
Okay.
How to, Dr. Gupta is asking how to mark.
Can I just a 30-second break? Just have some
Yeah.
water and come back. Yeah.
Yeah, sir, sure.
Okay. Just give me this.
हा व्हिडिओ एकदा चेक करून घे ना. राहुलने मला पाठवलाय चेंजेस करून. जर ओके असेल तर गोवाच्या
Hello.
Hello. Yes, sir.
Yes.
So I'll just read out the question. How come a canal in extreme osteoporotic jaw cannot be you cannot able to trace complete canal in osteoporotic jaw?
Yes. So it depends upon the what you say how porotic the jaw is. So what we need to do in such cases, we need to see where the nerve is entering and where the nerve is exiting. So we start from there, right? So what we do is generally we start from here and go anteriorly and mark the nerve canal. So in this such cases, we start from the mental foramen. So the mental foramen will give us the idea where it is exiting, and from that we go tracing it backwards, as in towards the lingual foramen. That will help us in identifying the nerve canal in cases of this thing, osteoporotic cases.
Okay. So next question is, in case if the CBCT is not available, how do you interpret using only CT scan only for implant planning?
It's the same thing. See, whether it's a CBCT or a CT, we need that same thing in DICOM format. So when we get that in DICOM format, we need to have some software in which we can open it. So there are many softwares which are available online, like Blue Sky Bio or Real Guide or even Carestream as Cbct. So these softwares you need in which you can open the CT scan also. So you need that scan in DICOM format. So once you get that, we can open it in any software and view it the same way which we use the CBCT.
How to detect incisive canal and accessory nerve canals in anterior mandible?
Yes, so incisive canals, they follow the same structure, the way you see your inferior alveolar nerve. So it will have that radiopaque border around it, and it opens outside the mandible. So inside this no lingual is, and anterior mandible it is always lingually placed at the center. And there are certain variations. So many times there will be a single canal which is going, at times it will be two or three, but they are typically at the what is the center, and you will see them opening out into the lingual cortex. So you will see that discontinuity at the lingual cortex in the shape of dots or points, which is the exit of this thing.
Perfect. Dr. Vinayak, I think it was such an eye-opener session. Even I got to learn so many new things and the small intricacies which you're sharing. And I think because the number of questions are just outgoing like anything, even if you keep taking all of it for the next 40 minutes also, it won't get over. And by that time, more questions will get added. So just you guide us how do you want it, or if doctors wanted, we can, because guided also a lot of us were keen on reviewing in detail. So how do you want it, sir? Do you want to like keep continuing because it's already around 1 hour plus session, and or we should, if you agree, start from where you left in a proper way with guided and take the Q&A for
So I will finish the guided, and what we can do is we can have a group where you can put in the questions and I will answer it there.
Sir, the thing is, no, because the doctors are there from multiple groups.
Okay.
There's no one specific group where I can put
Or
it.
you can share them my number with them and they can ask me personally.
Perfect. That is better. So what you can do, sir, you can just put your number whichever you want comfortable in the chat box. And then whenever we have any queries related to CBCT, I think it will be best that they get in touch with you.
Okay, sure.
Fine? Yes. So I will just make myself mute again, and I request you to complete on the guided implant surgery also. And post that we will not be taking up individual questions in the forum. You will be putting up your contact details. So doctors who have the queries, you can just get in touch with Dr. Vinayak one-on-one. Perfect, sir.
Yes.
Thank you so much. Please continue. Thank you.
Just 1 second. So now we have seen how to do a CBCT planning in the software.